Demystifying Optic Nerve Disorders. First, we have Neurological Visual Field Effects by Dr. Sujitra H. Dr. Sujitra is a professor and head of Department of Oculoplasty, Amrita Institute of Medical Sciences.
Good morning. Thank you, Dr. Rehana, for including me in this session. So, visual field evaluation is an important test modality in neuro-ophthalmological examination. So, when to do field test? When the visual loss is there and there is no ocular finding, or if there is neurological disorder that may affect the intracranial visual pathway. To locate the lesion, we need to do visual fields. So, coming to the visual pathway, it starts from optic nerve head, then to optic chiasma. In optic chiasma, the nasal fibers crosses to opposite side and the temporal fibers pass to the same optic tract, and in the lateral geniculate body, the next order neuron starts and the inferior fibers passes through temporal lobe and the superior fibers passes through parietal lobe and it ends at occipital cortex. Here in the visual fields, and the retina has an inverted relationship and reversed relationship. The superior field falls on inferior part of retina and the superior field falls on inferior part of retina, and inferior field falls on superior part of retina, and also the right field falls on nasal part of retina, nasal field on the temporal part of retina. Regarding the extension of the visual field, superior and nasal field extends about 60 degree, inferior field is about 70 to 75 degree, temporal fields 100 to 110 degree, and physiological blind spot corresponds to optic disc and it is located 15 degrees temporally in each eye. The automated static perimetry is the commonly used modality, and when fixation loss is less than 20% and if there is less than 30% false positive and false negative response, we consider that as reliable field. The field effect we can get when there is macular problem, optic nerve problem, or any lesion in the visual pathway. If the lesion is in the macular region, it can affect either side, either superior. It won't respect either vertical meridian or horizontal meridian. If it is in the So you can get central scotoma, central cecal scotoma, altitudinal field defect, peripheral constriction of field defect, according to the lesion in the retina. In optic neuritis, you can get either central scotoma, paracentral scotoma, centrocecal scotoma. In papilledema, in early stage, you can get enlargement of blind spot, and in established or chronic papilledema, there is constriction of visual field. So that is an indication of early intervention, early surgical intervention to prevent secondary optic atrophy. In anti-ischemic optic neuropathy, we get altitudinal field defect. When there is chiasmal lesion, we get bitemporal field defect because the crossing nasal fibers are affected. Pituitary adenoma and the craniopharyngioma are the common lesion causing chiasmal compression. And here we can assess the progress of the lesion by assessing the visual field. Okay, here you can see gradually the field effect is increasing, indicating enlargement of the lesion. In retrochiasmal pathway, we get contralateral homonymous hemianopia. If the hemianopia is incomplete, it helps in localizing the lesion. If it is complete hemianopia, that just says that it is an retrochiasmal lesion. It can be either anywhere from optic tract, lateral geniculate body, optic radiation, or occipital cortex. In optic tract lesion, it causes contralateral homonymous hemianopia and RAPD in the contralateral side and bow tie atrophy on the contralateral optic nerve head and temporal pallor in the ipsilateral side. So this hemianopia with RAPD means optic tract lesion. In lateral geniculate body, you can get contralateral homonymous hemianopia, and if there is small ischemia either at the anterior choroidal artery or posterior choroidal artery, we can get sector anopia like this. But this type of field defects are very rare. Coming to optic radiation, the postsynaptic fibers from lateral geniculate body passes as optic radiation. The inferior fibers passes through temporal lobe and the superior fibers passes through parietal lobe. So temporal lobe lesion causes superior incongruent homonymous quadrant anopia, and parietal lobe lesion causes inferior incongruent homonymous quadrant anopia. In occipital lobe lesion again causes contralateral homonymous hemianopia. It is most often congruent. Congruent means the field defect in both eyes are symmetrical, same. When the tip of the occipital lobe is involved, it causes central homonymous field defect. Okay. So it has a dual blood supply, and occlusion of posterior cerebral artery results in sparing of the macular field because it has blood supply from midcerebral artery also. So here in this field we can see the central 5 degree is spared. So it is classical of macular, classical of occipital lobe lesion. And lesion at the tip of the occipital lobe can result in small homonymous scotomatous defect. So here you can see small left homonymous central scotoma. Again ischemia causing right homonymous scotomatous defect. When there is bilateral lesion, it can cause vision loss that is symmetric in both eyes. Okay. So when there is visual field defect, we have to see whether it is reliable or not reliable. If it is not reliable, we have to repeat the field. If it is reliable and abnormal, if it is one eye is involved, that means the disease involving anterior visual pathway. If both eyes are involved, that is the defect and the defect visual field defect respects vertical meridian. The disease involves chiasma or retrochiasmal pathway. If it is bitemporal hemianopia, the lesion is at chiasmal region. If it is homonymous hemianopia, if it is contralateral retrochiasmal lesion, and the lesion is more posterior, that causes congruous field defect. So that's why that's how it helps in localizing the lesion. So here I'm showing a patient who presented with visual disturbance, and her field defect 30-2 field shows central scotoma and 10-2 showed sparing of central 5 degree, so indicating bilateral ischemia of posterior cerebral artery. And this is again a patient who showed spontaneous resolution of optic nerve glioma, and there is improvement in visual field defect too. Thank you.
Thank you. Thank you, Sujitra ma'am. Thank you, ma'am, for that nice talk covering most of the visual fields in neuroophthalmology. Next, we have a talk on electrophysiology, application in neuroophthalmology, often untouched topic in neuroophthalm. And this talk is by Dr. Nadasha Radhakrishnan, professor and consultant in retina, Amrita Institute of Medical Sciences.
Good morning to all. The electrophysiological test, as you know, is based upon the recording of electrical potentials evoked by visual stimuli, and either on the surface of the eyes, with the electrode situated either on the surface of the eyes, the periorbital skin, or scalp. They are non-invasive, and the important thing is they give, just like the visual fields, function-related indication. And it's of greatest utility when you have also a clinical scenario. And the ones that we are going to touch upon today are the pattern ERG, multifocal ERG, EOG, and visual evoked potentials are the types of electrophysiological tests that are important, but the visual evoked potential is most important in neuroophthalmology, so we'll be dealing with that in detail. The visual electrophysiological tests, like the ERG, what it does is to measure the change in the resting potential of the eye. In neuroophthalmology, the importance of ERG is in that if you don't know the ERG, you do not know if the ERG is normal, you can rule out that it is a retinal pathology. Otherwise, in neuroophthalmology, the ERG as such does, especially the full field ERG, does not have any relevance. The pattern ERG, on the other hand, is important because the macular fibers the function of the macular fibers is given by the pattern ERG, and this can directly convert to optic nerve function as well. So if you suspect a macular pathology, ideally you should have both the pattern ERG and the pattern VEP for you to make a distinction between whether it is a macular pathology or a optic nerve pathology. I will not go into details of the ERG. Again, the multifocal ERG also gives you some more information about the macula. So if you are suspecting something that is whether it is macular or whether it is optic nerve, again, multifocal ERG will also be important for you. This we have covered. So next we'll go to the important topic, which is the visual evoked potential. And this is an important test in the investigation of suspected optic nerve disease. And the diagnostic VEP, what we call the pattern VEP, is a reversing black and white checkerboard or grating. And this is of importance, especially when you want to look at misrouting of optic nerve and chiasmal fibers. The flash VEP is just a overall indication of whether the visual pathway from the eye to the brain is working or not. It cannot give us any more other information. And this measures the electrical signal generated at the visual cortex in response to visual stimulation, and it requires a relatively normal retinal or macular function to be a reliable test of visual pathway function, what we said earlier. The pattern reversal VEP will go directly into the components. I don't think we should go into the method. So this is what the pattern VEP looks like. There is a positive deflection at about 100 milliseconds. The negative deflections that occur at 75, what is called N75 and N135. Now reduced there are two things that we look at here, the latency and the amplitude. The reduced amplitude and increased peak time of P100 means the latency. So these two typically occur in optic neuropathies or optic neuritis, can also occur in maculopathies. That is why it is important for you to do the pattern ERG or the multifocal ERG earlier. And it should be read in conjunction with the retinal function test. So where do we use the pattern VEP? You can use it in optic neuritis, in multiple sclerosis, compressive lesions of the optic nerve, cortical blindness, unexplained vision loss, and also as a test of visual acuity. Now, in the optic nerve dysfunction, which is due to demyelination, the most important sign is the delay in the latency. Reduction in amplitude can occur in visual disturbance proximal to the optic nerve or neuronal tissue and is usually atrophic or ischemic, not demyelinating. Absence of VEP on monoocular stimulation again is a lesion of ipsilateral optic nerve. And we also talked about the prolonged P100 latency is an indication of demyelination. In optic neuritis, you know there will be disc pallor, thinning of the retinal nerve fiber once the it is Most diagnostic during the time of optic neuritis as well as in conditions of demyelination, this P100 latency almost never comes back to normal. So it is also an indication, especially in MS patients who have had subclinical optic neuritis. If you want to look at whether there was some optic nerve dysfunction during an episode, again you can look at the P100 latency. This is a delayed VEP 7 months following left optic neuritis in a 39-year-old male. And the delay is present both in pattern and flash VEPs. And however, right eye findings do not show any significant abnormality. The early optic neuritis nerve asymmetry. Early unilateral optic neuritis you can pick up if you have bilateral VEPs, and you can find that the left eye peak latencies are significantly slow. Pattern reversal VEP from bilateral optic neuritis, you can see they are symmetrically delayed. Later stage optic neuritis after initial onset showing progressively slower P100s. In trauma, what do we do? Use it in trauma for traumatic optic neuropathy. So immediately after severe trauma, if you have traumatic optic neuropathy, you can get no recordable VEPs. And however, sometimes it is because of the inflammation. So when you're doing it immediately after trauma, it should be interpreted with a pinch of salt, and you should repeat the VEP. Do not write off the optic nerve without repeating the VEP maybe a month later, so that because once the inflammation subsides, some amount of optic nerve function may come back. So even if the VEP is unrecordable, we can go ahead and repeat it later. Flash VEPs 1 month after occipital trauma showing some recovery of earlier one had no one at all, the one previously, and then now you can see that there is some amount of waves coming, and then 3 months after there is more further recovery. In patients with neurofibromatosis type 1 who have optic nerve gliomas, again VEP is a sensitive test for follow-up, because these patients, many of the time we do not intervene, and we look at visual acuity and visual fields ideally, but in these, sometimes with children you cannot look at visual fields and visual acuity. Because of that, the VEP follow-up is very important, because sometimes we finally intervene when the VEP is significantly showing changes over time. In other compressive conditions like hydrocephalus affecting the visual pathways, again VEP is important. Ischemic optic neuropathy, it is mainly to differentiate ischemic optic neuropathy from demyelinating optic neuropathy. So because of that, you will find that it is a decrease in the reduction in the amplitude without any change in the latency in non-arthritic AION, and more severe in arthritic AION. The pattern VEP in retrobulbar left eye neuritis, you can see that it is affected, and in the left eye of a patient with posterior ischemic neuropathy also you can see that it is affected, but the P100 will be normal. When you have an unknown cause of a pale disc, again you can quantify and follow the progression of optic nerve hypoplasia or optic atrophy or a pale disc due to any cause with the VEP. Another important thing that we use the VEP now for is the ethambutol toxicity. In screening, we cannot keep repeating the VEP every month, but if you have a suspicion that the patient has ethambutol toxicity, it is ideal to do the VEP and record the response, so that it gives you again a functional evidence that the optic nerve function is affected. And you will get delayed peak times in ethambutol toxicity. Next, another new one that has come is the multifocal VEP. Here, over 100 channels of the optic pathway are assessed in by the VEP activity is assessed. It's a new kid on the block, and it requires like a lot of studies to come out to know where we exactly can use the multifocal VEP. So in conclusion, the electrophysiological tests are an important thing in your armamentarium. You may not be able to use it all the time, but in some conditions, it definitely gives us an edge over our clinical examination and our other functional tests that we do. Thank you.
Thank you, ma'am, for that very nice talk covering the most important or the needed aspects of electrophysiology. Ma'am will be leaving now. Any questions to ma'am?
From the
from the
people.
from the two people.
Everyone else can ask at home.
Okay.
Okay. Total toxicity, you expect a decrease in the amplitude, not much in the വേണമെന്നില്ല amplitude reduction. The baseline VEP is not being addressed, but if you suspect that it's going on, you need a recording of the VEP showing a decreased amplitude. It will show before visual acuity drop, but again we can't use it as a screening tool because it is not widely available. So as of now, visual acuity, visual field, color vision and pupils are the way to screen, but visual field, especially the 24-2 or the 10-2, so are the way to screen. But if you suspect, before you send the patient for saying that it is a temporal toxicity, it is ideal that we do an MRI and a VEP also. MRI to rule out any other cause for optic nerve dysfunction, and VEP to record that there is definite optic nerve. Thank you.
Thank you, ma'am. Next talk is by Dr. Manoj. The topic is evaluating optic dyspallor. Is it glaucoma or neuro-ophthalmology? Dr. Manoj is professor and head of Department of Glaucoma, Amrita Institute of Medical Sciences.
Good morning to one and all. Also, let me thank Dr. Hannah for this opportunity. I'll be talking on disc pallor. Is it glaucoma or primary optic neuropathy? I purposefully did not mention consecutive or secondary because they are quite obvious. There is no confusion there. Acknowledgement to Dr. Wallace Alward, who has produced some of these beautiful photographs that I'll be showing. First and foremost is to listen to the patient. It improves patient-doctor relationship and helps make the right diagnosis. Also, let me emphasize the importance of a comprehensive eye examination, which includes visual acuity, anterior segment, disc and rest of the fundus, applanation with pachymetry and gonioscopy. But this talk will be centered around the optic nerve head. The best way to examine the optic nerve head is the slit lamp indirect ophthalmoscopy with 78 or 90 diopter lens. Use green filter for RNFL assessment. The drawback of examination technique is that it is impossible to assess the ganglion cell complex. Introduction to the glaucomatous optic neuropathy. It is a characteristic progressive optic disc cupping or thinning of the neural retinal rim. Those are the definitive features of glaucoma. The other neuropathies tend to leads to ganglion cell loss and pallor of the neural retinal rim. AION is an exception, and some of these AIONs can over time develop cavernous optic neuropathy. Not all cavernous optic neuropathies or cuppings are abnormal. Some of them can be physiological. When you have a larger disc, you expect a larger cup. The ISINT rule has very low specificity, and if you go on diagnosing glaucoma based on ISINT rule, then you will produce a lot of artificial glaucomas. Calculating the disc size, if you are using 90 diopter lens, then you can multiply it by 1.3 to get the measurement of the optic disc. This is an example of the physiological cupping, about 0.7 CD ratio you can see, but you can see the neural retinal rim and NRR are healthy. Some of those abnormal situations like a tilted disc, drusense, they fall outside the preview of this talk, so I will not be going into details on how to diagnose glaucoma in such situations. The supportive signs are again supportive. They lack specificity, but we will be discussing them in the subsequent slides. First, let us look at normal optic nerve head. They are usually slightly vertically oval, and the size ranges from 1.5 to 2.2 millimeters diameter. Symmetrical usually, and normal cup disc ratio ranges from about 0.1 to 0.4. And remember that about 5% of the population can have a cup disc ratio more than 0.6. So going by CD ratio, you'll overdiagnose glaucoma. So that is not just the way. So let us look at the definitive changes of optic nerve head glaucoma. Enlarging or progressively enlarging optic nerve head cupping is definitely a sign of glaucoma. So this is an example of a patient who has been followed up for 35 years, starting with a cup disc ratio of about 0.4. It is ending up with a 0.9 cupping over 30 years. What should you look for? examine the inner contour of the cup. Look at if it is concentrically going or there are any irregularities like a focal polar thinning. The polar thinning can be focal or diffuse, or there is a notching. There usually will be a corresponding retinal nerve fiber layer defect as well. Look at the cup disc asymmetry. In a symmetrically sized disc, when you see a cup asymmetry, then that is very specific. And disc hemorrhage in the presence of cupping is again another symptom of sign of glaucoma. Not all asymmetrical cuppings are glaucoma. If the disc size itself is larger, then the cup can also be larger. Like this case, you can see if you just look at them separately, you may completely miss this. So keep those photographs together and then compare. Also, this is evident in the OCT as well. Disc hemorrhage, unless you keep looking for it, it will be missed. And this photograph is an excellent tool to actually evaluate for disc hemorrhage. You can see an inferior neuroretinal rim thinning and a corresponding RNF defect and the disc hemorrhage on the edge of this defect. You know that this is a sign of progression or an activity, and over time the RNF defect is going to enlarge towards the disc hemorrhage side. The other ONS changes of glaucoma, like the peripapillary atrophy, bearing of circumlinear vessels, bionoting sign, lamellar dot sign, or nasalized blood vessels. Peripapillary atrophy, we have alpha and beta. The beta is what is usually associated with glaucoma, but 25% of normal population can also have beta atrophy, so it is not a specific sign for glaucoma diagnosis. Bearing of circumlinear vessels, as you can see, this patient as the disease has progressed, there is a bearing of over there you can see that that blood vessel is not supported by the neuroretinal rim. That's called as bearing of circumlinear vessels. Bionoting is when a vessel completely disappears and then appears on the surface. So that happens in advanced excavations or advanced glaucomas. Lamellar dot spine is again non-specific. They just mean that the cup is deep. It can be physiological or glaucomatous deep cup. So when you have loss of neuroretinal rim and in that particular zone there is a lamellar dot sign, then that becomes significant. Retinal nerve fiber layer defects are usually there and they are very obvious on disc photography. Wherever there is a neuroretinal rim thinning, and if you have normal healthy the RNFL on either side of the defect, you will see it like it has a defect. If it's a very large area of loss, then you will not see a defect, but you will see a broad area of RNFL thinning. This is a patient who has progressed from near normal to inferior loss and a RNFL defect with a disc hemorrhage. When you have a tessellated background, you may not see the RNFL defects evidently. So OCT plays a better role in these situations. So you can see the superior NRR is thin and RNFL is broadly defective, but there is no defect as such you see in this tessellated background. Red-free images are a very good useful way of assessing the RNFL changes. This is a picture of glaucomatous optic atrophy. Optic nerve and peripapillary examination is the key for glaucoma diagnosis. So can you have cupping and not glaucoma? Yes, like I already mentioned, AON is an example. Also, when the cupping was there earlier itself and the insult happened later, so it can be any type of insult. It can be glaucomatous insults or other insults. So in such situations, it may be confused with glaucomatous optic neuropathy. Some of those consecutive optic neuropathies like an old branch retinal vein occlusion can sometimes come as focal inferior or superior neuroretinal rim thinning. Some of these cuppings are classical cuppings of glaucoma are actually prior glaucoma insults like in a steroid-induced glaucoma, and over time as the steroids have been stopped, the IOP has come down to normal and then they are not usually progressive disease. Can you have pallor and no cupping and still have glaucoma? Yes, it is possible in patients who have specific type of glaucomas where there is possibility of acute rise in IOPs. So such acute attacks can cause pallor. Quite often we see them in angle closure glaucoma and some of these secondary glaucomas like silicon oil glaucoma or uveitic glaucoma. Visual field defect occurs after significant physiological damage occurs. RNFL and ganglion cell changes precedes visual field defect. Let us look at a few examples. This is a patient who has a Durham scotoma, Derringer scotoma superiorly, If you see this RNFL defect, they are coming close to the fixation. This angular distance is quite small. In such situations, you will have involvement of the GCC on the GCC map and a field defect closer to the fixation. This is a patient who has a wide angular width, and this field defect is away from the fixation and that is not involving the macular GCC. This shows a primary type of optic atrophy seen in a pituitary macroadenoma. There is binasal loss of GCC, bitemporal hemianopia, and temporal pallor on temporal thinning on RNFL OCT. Another example, you see temporal thinning in the deviation and thickness map, a generalized depression on total deviation, and pattern deviation is looking normal, whereas total generalized reduction in the thickness in the GCC map of macula. Another example, this is the patient who I recently saw, the last slide. This patient was a non-case of primary angle closure, status post PA, IOP control on single drug, who did not have any visual field defect. Patient presented with complaints of blurring of vision 1 month prior. So examined, the IOP was normal, the disc was looking the same, but I subject the patient to a field and keep the fields together. Then you can see that there is a right homonymous hemianopia developing. Otherwise, the OCTs are looking exactly like the previous OCTs. So I subject the patient for an MRI, and this is what we got. A subacute infarct in the occipital lobe anterior to the posterior horn of the left lateral ventricle. So take home message or take clinic message. Don't take it home. Get a detailed history, clinical examination first, then correlate with available investigations. Thank you.
Thank you, Dr. Manoj, for that good talk on optic disc pallor. Can I have a question? Dr. Manoj, so with the disc, looking at the disc, when would you ask for imaging or like a neurological evaluation? What are the warning signs that would prompt you to?
Yeah, if I see a temporal pallor, that is what normally people get confused with. When you see a small pallor, is it physiological pallor like in a myope or a tessellated background, or sometimes in a pseudophakic, or is it actually pathological? I think we can first suggest the patient for at least a bare basic visual fields to see if there is any neurological pattern. If it is not there, then I don't further investigate.
Okay, thank you. Next, we have Dr. Sanitha Satyan. She's going to give a talk on approach to disc edema, a case-based discussion. Dr. Sanitha is a medical director of Vettam Eye Hospital, and she's a pediatric ophthalmologist. Over to Sanitha.
Thank you, Dr. Rehna. So I'll be talking about approach to disc edema. So first thing about disc edema is to differentiate between a true and a pseudo disc edema. Pseudo disc edema can occur in congenital anomalies, optic nerve drusen, Burgmeister's papillae, morning glory, sometimes may give a false impression of a true disc edema, myelinated nerve fibers, even hypermetropia and tilted disc, glial tissue proliferation over the disc, drag disc, dysplastic disc. All these conditions we might feel that there is a disc edema, but basically it's a clinical diagnosis. Of course, you can use some ancillary investigations to differentiate that too. So in a true disc edema, there will not be spontaneous venous pulsations. Retinal striae, engorged veins, retinal hemorrhages, fluorescent leakage, all are features of true disc edema. Enlarged blind spot may be seen in some optic nerve drusen as well. Examination of optic nerve or disc edema. First thing is visual acuity. Depending on visual acuity itself, we could suspect some diseases like an AON or optic neuritis or papilledema. In AON, especially with the arthritic one, you have a more severe visual acuity loss, whereas papilledema and optic neuritis may not present with that kind of a visual loss in the early stage. So pupils, RAPD in unilateral diseases involving optic nerve, it is very common to get a RAPD. Color vision is also a very important test when you talk about disc edema, because color vision may be grossly defective, or in some cases like optic neuritis, you can actually have a color desaturation. Contrast sensitivity is also affected. Visual fields, we have had a exhaustive discussion on that. And basic thing would be a disc appearance, which would help us to discern some causes as such, like optic neuritis or AION. And spontaneous venous pulsations, we have already talked, and RNFL opacification also may be seen. The next thing would be to differentiate, it would help you to differentiate the diagnosis also, whether it is a unilateral disc edema or a bilateral. All unilateral cases may go into a bilateral one later. AON is the classical unilateral disc edema, neuroretinitis, optic neuritis, papillitis, papillophlebitis, retinal vein occlusion, ocular hypertony, Foster Kennedy. All this can present with unilateral disc edema. In bilateral cases, there could be compressive lesions, infiltrative lesions, diabetic, hypertensive papillopathies, systemic diseases like Graves causing bilateral disc edema. Cavernous sinus thrombosis, CCF, and LHON all can cause bilateral disc edemas. So this is a case where a 24-year-old female presented with headache and vision. Her only complaint was occasional headache. Visual acuity 6.6 in 6, color vision is normal. When you look at the disc, you can see there is hyperemia of the disc with blurring of margins. And investigations also, there is some enlargement of the blind spot on the perimetry. MRI, MRB was done to rule out cortical vein thrombosis, which turned out to be normal. And CSF study, we know this clinches the diagnosis with high opening pressure. It's a idiopathic intracranial hypertension. So you have a lot of people who are asymptomatic, especially young females who come accidentally to your OP for some other things, and they are diagnosed with idiopathic intracranial hypertension. And it can be, I think we ophthalmologists see them first, and diagnosis is very critical because it actually gets cured over with use of proper medications. And case 2 is a 40-year-old female who presented with sudden painless defective vision of 1 week duration. She was actually diagnosed case of mixed connective tissue disorders, and the vision in left eye was hand movements. That is a much higher visual loss, and left eye had an RAPD. This is the fundus photo. You can see the disc edema in the left eye, and also in the OCT and in the FFA, where you can, in the late stages, there is a disc leakage also. And VEP also, there was a change. So this is a left arthritic, non-arthritic ischemic optic neuropathy. In case 3, this is a 38-year-old male with sudden defective vision. So he had painful eye movements. This is a very typical feature of optic neuritis. And the vision was 636 in the right eye with grade 3 RAPD. And color vision was also impaired. BP was normal, and he had a optic nerve thickening in the MRI. So this is a right eye optic neuritis. Optic neuritis can have many causes, and depending on that, most of them systemic causes are also. So you can have a classification of demyelinating, infectious, para-infectious, and others. So in the demyelinating group, we have the most common one, most important one, multiple sclerosis, usually in young adults. And sometimes they might present, usually I think 15 to 20%, the first symptom may be a optic neuritis of multiple sclerosis, and most of the patients, like 50% of multiple sclerosis patients, they might have a episode of optic neuritis somewhere in the course of the disease. And then neuromyelitis optica and other Schilder's disease, encephalitis periaxialis concentrica, all these are demyelinating causes. Lately now new antibodies are also being investigated, and especially in Devick's disease, NMO-associated optic neuritis. And infectious and para-infectious causes, virus, adenovirus, Coxsackie, measles, mumps, rubella, varicella, all this can produce optic neuritis. And also bacterial causes, tuberculosis, syphilis, Lyme's, cat scratch, streptococci, all this can actually cause optic neuritis. People do come with post-vaccination optic neuritis. Diagnosis is a bit tricky, but there cases are reported in this. Inflammation, sarcoidosis is an important cause, and many other causes like Guillain-Barré, birdshot retinochoroidopathy, toxoplasma, toxocara, all can present with optic neuritis. So now let's go to cases of bilateral disc edema. So this is a typical papilledema, and the disc edema is much pronounced. So causes can be one due to cerebral edema. The classical one we see in a cortical vein thrombosis, idiopathic intracranial hypertension or hydrocephalus. The second classification would be a compressive optic neuropathy, in which the compression can happen at any level of the optic disc, optic nerve, intraorbital, intracanalicular, optic chiasmal, or even in the optic tracts. So you can have optic nerve sheath meningiomas, thyroid associated orbitopathy, idiopathic orbital inflammatory syndrome, and suprasellar tumors, classical one being pituitary adenoma, craniopharyngiomas, aneurysms of internal carotid, carotid and ophthalmic arteries, anterior communicating arteries, sphenoid sinus, mucocils, and fibrous dysplasias involving the sphenoid bone. All this can cause compressive optic neuropathy. Another group would be a infiltrative optic neuropathy. These cases do come to our OP, and sometimes it may be the first ever presenting symptom of a leukemia or a lymphoma. I had a case recently. So primary tumors can present, primary tumors of the optic nerve, like an optic nerve glioma associated with NF1 and ganglionomas, and secondary tumors like lymphoma, leukemia, leptomeningeal metastasis, inflammations like sarcoidosis, infections, tuberculosis, toxoid, crypto, all this can present with infiltrative optic neuropathy. One last word about toxic optic neuropathy. Usually we all see these cases in the post disc edema stage with pallor, but in acute stage actually they can present with disc edema as well. All this chloramphenicol, ciprofloxacin, linezolid, sulfonamide antibiotics have a potential to develop toxic optic neuropathy. So as anti-malarials, ATT drugs, chemotherapeutic agents, even antiarrhythmics, antiepileptics, and even in methanol poisoning we have seen such cases, and heavy metals and carbon monoxide, tobacco, all this can produce toxic optic neuropathy. So this was a nutshell about disc edema. Thank you for your patient listening.
Thank you, Dr. Sanida, for that very nice talk. Questions we'll take at the end. So next topic is OCT. Is it mandatory in neuro-ophthalmology? Myself, Dr. Rehna, will be presenting it. OCT, is it mandatory in neuro-ophthalmology? So in neuro-ophthalmology, OCT can be used objectively to assess the structure of the optic nerve head and peripapillary retinal nerve fiber layer. The peripapillary retinal nerve fiber layer is actually the axons of the ganglion cells. It has the advantage of giving this reproducible and quantifiable measurements. The thinning of the peripapillary RNFL is an objective marker of optic atrophy, but to give a complete picture, they have to be performed in conjunction with subjective assessment of optic nerve functions like visual acuity, color vision, and visual field examination. First, let's have a look at the way the fibers are represented on the retina and optic nerve. So if we take the fovea as a center of fixation, the fibers from the temporal aspect of the fovea is the temporal fibers, and the nasal aspect is the nasal fibers. So these blue fibers, the nasal fibers, are crossing at the chiasm. So papillomacular bundle represented in the temporal aspect of the disc, and these fibers at the nasal, and the temporal fibers at the superior and inferior aspect of the optic disc. So quantitative measurement is the one which we usually do in assessment of neuro-ophthalmological cases. So we look at the thickness of the peripapillary retinal nerve fiber layer, which with the average reading you can get it from here and the sectoral readings from here. Similarly, we also get the thickness of the ganglion cells. So let's go to few cases. This is a 23-year-old lady presenting with headache with a visual acuity of 6.6 in both eye. The disc showing bilateral disc edema. So what is the most probable diagnosis? Papillary edema. So obviously in the RNFL we would be finding out this marked thickening of the retinal nerve fiber layer, which is shown as white in color, and that confirms it. And to investigate, the patient was investigated with MRI and the CSF pressure was found to be high. The diagnosis is idiopathic intracranial hypertension. So here the use of RNFL, OCT RNFL is not for the diagnosis, but when you are treating the patient, the sequential scans make it possible to monitor the patient, to know the response and when to stop the treatment. And it's also effective in such cases where we're not very sure whether the optic disc is thickened or not. It would confirm the thickening. And there is a study which is based on OCT, which is idiopathic intracranial hypertension treatment trial, which showed a greater reduction in the mean RNFL thickness among the Diamox patient compared to placebo. So regarding our first patient, the patient was started on Diamox and slowly the thickness reduced, came back to normal. Now we'll go to the second case. This is a 6-year-old girl who came for routine examination and gave a history of occasional headache. Her visual acuity is 6.6 in both eye with hypermetropic correction. So if you look at this, there is slight margin blurring superiorly and slightly hyperemic. So you will be in a situation whether it is an early papilledema or is it a pseudopapilledema. But to diagnosing that is very important, because in case of pseudopapilledema, if you are diagnosing pseudopapilledema in a case, that would avoid unnecessary investigations like MRI and lumbar puncture. But diagnosing a papilledema, which is there, is also very important because it would be associated with serious neurological disorders. So if the OCT RNFL comes out like that, that's ruling out papilledema, most probably pseudopapilledema. But most of the cases we have found that it comes up something like this. There is some thickening of the peripapillary RNFL layer, where again we are confused whether it is an early papilledema or a pseudopapilledema. In such cases, we can go for B scan or FFA without leakage would confirm that there is pseudopapilledema. Also in OCT, there is another way by which we are looking at this RP basement membrane hyperreflective layer. This is a scan which is done HD OCT, which is done through the optic disc. So if this hyperreflective layer in normal patients, in normal individual, it's turned away from the vitreous, which is negative. But in case of papilledema, because of the biomechanical forces which are acting on the load-bearing structures, it can turn into the vitreous. So that can be also used as an ancillary test in diagnosis. And in case of pseudopapilledema, you would also be able to see these hyporeflective lesions surrounded by hyperreflective margins, which are actually drusen's in pseudopapilledema. And again, you can note here, this is turned outside, away from the vitreous. So we did a study on this angle between papilledema, pseudopapilledema and normals, and we found that around 70% of the patients with papilledema had an angulation which is turned towards the vitreous, and the rest were neutral, that is flat, and we didn't find any negative values. But in pseudopapilledema and normals, either neutral or negative values were there. Now let's look at the next case. Young girl with a decreased vision in the right eye, pain on eye movements. Visual acuity is 6.24 in the right eye and 6.6 in the left eye, with RAPD in the right eye and defective color vision. What is the diagnosis? It's optic neuritis. So here, the disc, the field was showing centrocecal scotoma, and this is something we do expect because the disc was edematous. So that would help to quantify the amount of thickening. So that is helpful, but it's not required to repeat the OCT RNFL every visit, because that's not going to help in the management. But in MS patients, as it was discussed before in the ERG VEP, OCT can detect subclinical axonal loss, even in those patients who never had an optic neuritis, and so we can know that the patient had subclinical optic neuropathy before. And also it's been found in studies that macular edema and thickening of the inner nuclear layer on OCT were associated with disease activity and worse disability in multiple sclerosis. And also the ganglion cell loss is a predictor of short-term visual field improvement, like color vision or contrast, which usually happens later in course of the disease. The other use of OCT in neuro-ophthalmology is as a prognosticator for cellular and paracellular tumors. So in cellular and paracellular tumors, the visual field defects and the visual field improvement, to an extent, a lot is dependent upon how much damage it's caused anatomically to the structures of the eye. So let's look at a case. This is a patient with a cellular tumor. And you can see the visual field defect. There is temporal heminopia, superior temporal heminopia here. And if you look at the OCT, RNFL and ganglion cells, there is not much change there. And the patient underwent surgery. And 1 week after the surgery, the visual field has completely returned to normal. On the other hand, if you look at this picture, there is a marked thinning of the RNFL and GCC here. If you look at this type of loss, it's a binasal kind of ganglion cell loss, which occurs very typically in cellular tumors. That's because these are the nasal fibers which are actually crossing at the chiasm. So this was a visual field defect, bitemporal hemianopia. And after surgery, this is 6 months post-surgery, the visual field didn't improve completely. It did improve, but it didn't improve completely. Another use is in ethambutol toxicity, like drug toxicity. Nowadays, we are seeing more of the ethambutol toxicity patients. As we know, the dose of the ethambutol has been increased and the ethambutol has been stretched onto the continuation phase. So there are a lot of studies which are being done to know whether we can detect subclinical optic neuropathy in patients so that the drug can be stopped. And these studies have shown that there is initially there is some thickening of the peripapillary RNFL and later on thinning, which occurs later after 6 months or 8 months, especially in patients who are higher dose and a longer duration. Okay, but there is no consensus regarding whether to stop the treatment just based on that. We have to go with the findings with visual acuity, color vision, contrast, and fields. Now, another area where studies are going on is in Alzheimer's and Parkinson's, where they have found thinning of the RNFL in both the conditions, and it's more marked in upper and lower quadrant, not in the nasal and temporal quadrant. So such findings indicate that the loss of the retinal ganglion cells may reflect more widespread degenerative changes in the brain. So to summarize, the uses of OCT in neuro-ophthalmology, one is papilledema and IIH to diagnose and to monitor the treatment, pseudopapilledema to differentiate from papilledema, and in optic neuritis and AION to quantify the thickening and also to prognosticate the visual recovery, and drug toxicity, and as a prognostic predictor for cellular and paracellular tumors pre-surgery. Thank you.
Thank you, Dr. Rehna. It was a very informative presentation on the use of OCT in optic nerve disorders. We have 3 more minutes for discussion. If you have some questions, please come forward. I have a question to Dr. Rehna. When you have a patient with IIH, you use OCT to clinch to your diagnosis, and then when would you like to repeat the OCT? Will you repeat the OCT?
Once the treatment is started, after 4 weeks, we do repeat it, and we have found changes in the quantitatively decrease in RNFL. The treatment is usually started by the neurologist in our setup. They start on usually Diamox, and they do continue for quite a lot of time period, like 3 to 6 months. So we do follow up the patient every month till then. Yes, yes. Any other questions? Yeah.
How would you order for RPBM section in a case with leukemia?
Actually, not all the cases are showing positivity, but still we can do the raster through the disc initial presentation. Whenever the patient presents to us, initially itself do it. And what we have noted is that tilting to away from the vitreous, which is seen in normal, is altered, even in early papilledema. So it would help in a way that if it is purely negative and the patient doesn't have any warning signs of papilledema or increase in intracranial tension, we don't have to rush in for the further investigation. At least we can follow up the patient after 2 weeks or 4 weeks and see whether there is any quantitative increase in RNFL and decide based on that. So that gives more peace of mind. Yeah, we can do that. In there also, if it is not papilledema, that change in the RNFL will not be there. But it all depends upon the eyes, so we have to take it with all other investigations and clinically. So it's done at the initial presentation itself. So we'll stop. Thank you, everyone.